I would like to welcome everyone to the final session of the seminar series of the Center for Institutional Studies at the HEC University in Moscow. We're very pleased to have as our speaker for the last seminar of the year, Professor Katherine Meckel from University of California, San Diego. Katherine is an economics professor at UCSD. She is also an NBR faculty member. Her fields are public finance, health, and environment. She published extensively in top journals, and much of her recent research was on depression and smoking and health implications. So she's following this field that was established a long time ago by Gary Becker, where economists study all sorts of deviant behavior. And tonight, Catherine's talk is on cigarette taxes, smoking, and health in the long run. Katherine.
Great, thank you. Thanks for inviting me. So I think just to make sure, we said about 45 minutes for the talk. So
yes,
we'll go
about that, if you please, right.
Okay, perfect. And I'm happy to have people speak up and ask clarifying questions during the seminar. So this paper is co-authored with a number of people, Andrew Friedston from UC Denver, Moyan Lee from Indiana University, also Daniel Sachs from Indiana University, and then Dan Reese, who just moved from UC Denver, which is University of Colorado, to the Universidad Carlos III in Madrid. Okay, so, oops. All right, so in 1964, the Surgeon General in the United States came out with a very influential report that warned Americans and really kind of linked definitively smoking cigarettes to certain hazards, including lung cancer, heart disease, and COPD, chronic obstructive pulmonary disorder. And what followed in the United States, and to a certain extent in other developed countries, is increasingly aggressive tobacco control policies. So we have taxes on cigarettes, bans in public and private places, et cetera. And as a result, there was a very large decline in smoking. So from a data source, a large survey on health, the rate of smoking among adults was 42.4 in 1965 and declined to 13.7 in 2018. Okay. To estimate the welfare gains associated with these policies, we need causal effects of smoking on health, right? Causal effects really of the policies themselves that operate by changing the incentives to smoke. And a lot of the long-run mortality effects that are often quoted by public health officials in subsequent Surgeon General reports derive from correlational studies, from retrospective and prospective studies, where they compare smokers and non-smokers. They compare the mortality rates between these two populations, and they adjust for certain observable differences like age, education, sex. But as should be obvious, doing a long-lasting randomized control trial that would uncover the effects of smoking on mortality is both probably infeasible from an ethical point of view, and also if you're trying to measure the effects over a lifetime, it is infeasible from a cost view. Okay, and so these studies conclude, one of the most famous ones concludes that smoking reduces your life by 10 years, smoking throughout your lifetime. The problem, obviously, we know is, as economists who are well-versed with causal estimation, is that there are going to be unobserved differences that cause selection into smoking, including how risk-loving you are, potentially what your underlying health is. So there's been something observed where people who are less healthy might select into smoking because it's called a Mickey Mantle effect. It was a famous baseball player who said he smoked because he thought he was going to die early. Anyway, so we'll talk a little bit about that when I do the literature review. Okay, so what do we do in our study? We're going to match variation in state tax rates. So something that's nice from an causal inference point of view is that not only is there a federal tax on cigarette packs in the United States, but there's also variation in the state and municipal tax rates on cigarette packs. We're going to use variation in state rates to control for unobservables. And so we think of this as kind of exogenous policy variation. And in particular, we're going to match the tax rate that people faced as teens. So the pass through from taxes to prices is thought to be about 1-for-1. And so this is a way of instrumenting for the price. Prices themselves may be a bit more endogenous to local and economic factors. So we match the teen taxes to these teen, what I'm going to call teen tax is going to be your average tax in your state of residence when you were a teen from age 14 to 17. We're going to match those to adult smoking and mortality outcomes. Why teen taxes? Like, why is that a design that would be good? There's a large body of literature now from which I quote selected papers showing that teens are particularly price sensitive to the price of cigarettes, more so than adults, especially in the decades that we look at, in terms of the decades and the people we are studying were teens. We know from epidemiological studies that almost 100% of adult smokers in the US start as teenagers. And from a related paper that I have with the same group of co-authors, we actually show that the deterrent effects on teen smoking are persistent, that they have a causal effect on whether or not you smoke as an adult. So it's not just that they delay the decision of smoking, but that they're actually going to reduce the likelihood that you end up smoking later in life. Okay. I'm going to go over this in some more detail, and so I might go through this quickly. This is still the preview, but we have tax data that includes state and federal taxes. We're going to put it in $2005. As I was just saying, we match those taxes to 14 to 17-year-olds. Our main specifications are going to adjust for state and year fixed effects. And in this case, the identifying variation is going to come from changes in state taxes and also from inflation a bit. So if you think about the fact that these state and year fixed effects are going to control for level differences, but then when you divide the prices by, when you divide the tax by inflation, there may be some residual variation that's driven by inflation. And this bullet point is in part because many people think that a lot of the cigarette tax variation in the United States really started in the late 90s. I'm going to demonstrate that there was actually some important state variation in the 50s through 70s, which is when our cohorts were teenagers. Okay. We are going to look at adult smoking using the tobacco use supplement of the current population survey. So this is for the adult outcomes. We're not going to look at teen smoking. Okay. So we're going to look at cohorts that were born from 1943 to 1998, age 20 to 75, when we measure their smoking outcomes. And our main headline finding there is that a $1 increase in $1 increase in teen taxes reduces adult smoking by 8%. This is actually a pretty novel finding. There is very scant evidence on the long run effects of teen taxes on adult smoking rates. We find that there's great greater tax sensitivity for men who experienced these increases in tax rates when they were teens. Okay. So this is somewhat similar to recent work. So this paper looks at the concurrent effects of teen taxes on teen smoking, right? Again, we're looking at the long run effects, which we would expect to be somewhat smaller because there are going to be some people who are deterred, but it really does just delay their smoking decision. Okay. And so these two papers, one of them, which is what our other paper says, that the same treatment effect reduces teen smoking concurrently by 10 to 20%. So we're thinking of a long-term effect of being a bit smaller than that. Okay. And then in addition to looking at long-run effects on smoking, I think the big innovation of our study is that we're able to look at long-run effects on mortality. Part of the reason this is an innovation is because, well, it's an innovation by definition, but we just didn't have these years of mortality data that would really allow us to trace out the mortality effects at older ages and match them to decades where there really was a lot of tax variation. And now that enough time has passed, we can do that. So we use the universe of US death certificates from 1990 to 2018. Same cohort, same ages as the smoking data. I'm going to go over the model in a bit more detail when I get there. Our headline finding there is that a $1 same treatment effect increase in average teen taxes from age 14 to 17 reduces adult mortality by 6%. Okay, and so that's going to be average mortality over the years 20 to 75. The average adult in our death certificate sample is 40. Okay, larger effects, we observe larger effects for men, which correlates with the fact that we see more price sensitivity among them, and 75% of the effect is driven by diseases that are likely caused by smoking. You might think, well, why isn't 100% of the effect? I'll get into why there may be some error there. And then what's really nice is we're able to look at placebo causes that we wouldn't think would be affected by smoking behavior during your lifetime, like homicides, and we see no effect on those causes. Okay, so let me get into some of the background and related literature. So I touched on this. Here we have actual citations. Many studies establish a link between smoking and ill health. We're not the first to do that. The long run studies where they're looking at mortality are largely these prospective and case control studies that are trying to compare smokers and non-smokers and adjust for observables. There's also, in a more causal framework, a number of papers, these are just a couple, that look at effects on infant health of prenatal smoking, right, and find adverse effects. And so as I was just saying, some of the most quoted studies on effects on life expectancy are these kind of early and then follow-up studies. These are famous studies that use a large prospective and then retrospective sample of male doctors in the UK who were surveyed about their smoking habits. And then in 2004, this Dahl followed up and looked at their long-run mortality outcomes. At the same time, there's a number of papers that show that there are these unobserved differences between, so if you can control for observables, but it's harder to control for unobservables, that might create bias in these estimates. As I was saying before, there's unobserved differences in health between smokers and non-smokers, underlying health that's not necessarily caused by the smoking, and then also in terms of the risk preferences. Okay, in a structural model and a series of papers, Darden et al. And Darden 2017, say that this unobserved underlying health parameter explains about, that varies between smokers and non-smokers, explains about half of the 10-year gap in life expectancy. Okay. So, so in order to, as I was saying, in order to control for that unobserved variation in health and in prudence, a number of papers use cigarette taxes. Okay. There is some prior work on the long run effects of cigarette taxes on smoking and mortality, and to quickly go through that, there's these 3 papers, one of which is our related paper, this one. Look at the long run effects of cigarette taxes on smoking. Gruber and Zinman do this in a sample of pregnant women where they match, when I say long run effects of cigarette taxes, I do mean the effects of teen taxes. So they match teen taxes to birth outcomes. So the teen is the mother who then later gives birth. And then in this paper, Gliad matches teen taxes to later smoking, but doesn't correct for state level differences, which might create some bias if we think that there's other differences across states besides taxes that correlate with health. In our paper, we find persistent effects of teen taxes. The headline there is that 10 fewer teen smokers leads to 5 to 6 fewer adult smokers. Okay, and then finally, our paper is related to some prior work on the contemporaneous effects of cigarette taxes on adult mortality. There's this paper by Michael Moore from 1996, where he finds that an increase in contemporaneous state taxes reduces adult mortality due to heart disease and cancer. 1 year later, and then Bowser et al. Find that state tax increases reduce all-cause mortality at the state level 5 years later. These 2 papers suggest that it will be important to control for adult cigarette taxes. Okay. So let me get into some of our data. I'm very happy to answer any clarifying questions you might have. So the tobacco use supplement of the current population survey is going to be the data set that we use to measure long run effects of teen taxes on adult smoking. Okay, so this supplement was sponsored by the National Cancer Institute. It's cross-sectional about every 3 years from 1992 to 2018. So we use 10 waves. It's nationally representative, and the smoking measure is whether you smoke some days or every day in the month in which you were surveyed. Okay, that's how we're going to code this extensive margin smoking participation measure. Importantly, for our purposes, the TUS CPS, which is what I'm going to call it, it measures state of residence, age, and sex. So we're going to use state of residence in adulthood to proxy for your state of residence when you were a teen, when we're using this data set. Okay. Fortunately for the mortality data, we observe both the state that you're living in when you die and also the state in which you were born, which is probably a better proxy for the state you were living in when you were a teen. So in terms of sample restrictions, to get at adult smoking habits, we're going to limit the samples of people who are aged 20 plus when they're surveyed. We also need them to be born in the United States so that we can assume that they were facing taxes in the United States during their teen years, currently residing in the United States. And we're going to limit the sample also to those that have non-missing smoking measures and controls. That ends up giving us limiting us to cohorts that were born in 1943 and later. And a reason for that is that we're going to want to control for certain economic variables measured during the time you were a teen. One of those is the state unemployment rate. We have the state unemployment rate starting in 1957. And since we want to match that to ages 14 to 17, if you do 1957 minus 14, that gives you birth cohort 1943 and later. And we end up with a sample per wave of 106,000 individuals. Okay, for the mortality data. So the National Center for Health has this vital statistics, multiple cause of death data. We use this from 1990 to 2018. Starting in 1990, for a couple of reasons, although we're currently working on expanding it further back. The death certificate in the United States was redesigned in 1989 and starting in 1990. And so there's some very important differences across those 2 years. And so what is the death data? It's going to give us individual level data on the universe of deaths in the United States. This provides us with an underlying cause of death using ICD codes. Gives us the person's birth cohort, it gives us their sex, and then also, as I mentioned, importantly, it gives us their state of birth. Okay, so that's going to be a proxy for the state you live in during your teen years. Similar reasoning brings us to the same sample restrictions. We want to observe adult deaths, so we're going to limit age 20 plus. Again, because of the availability of some of the teen dated controls, we're going to have cohorts to 1943 and afterwards, born and residing in the United States. And here our sample per year of deaths is 519,000. So one of the important things that we do is not only are we going to look at overall deaths, but we want to show that because we can't observe smoking on the death certificate, that the deaths that are deterred by not smoking as an adult are indeed those deaths that would be caused by smoking. So the Center for Disease Control in the United States has this definition of smoking related mortality that we're going to follow. So it's important to think about this definition. So these diseases that we're going to use are those for which there exists sufficient evidence, which they're going to draw from medical studies, to infer a causal link between smoking and to infer a causal link, saying that smoking indeed causes this type of disease. Okay, so these are specific types of cancer. So some examples are obviously lung cancer, esophageal cancers, which is like your throat, stomach cancer, specific types of respiratory disease and heart disease. And then one that was added recently because they decided there was enough evidence is diabetes. So this is a nice measure, but it's not perfect. It's going to include diseases that are not caused by smoking. Okay, we think that within these causes, about 30% are directly caused by smoking, but because we can't observe smoking on the death certificate, there are many other things that cause diabetes, for example, or heart disease. And it also excludes this host of associated diseases that the CDC thinks are linked to smoking, but they don't have enough medical evidence for. So diabetes was one of those diseases for a while, and deaths that are indirectly caused by smoking. So house fires, if smoking makes you more likely to engage in substance abuse, and then the fact that smoking can aggravate other diseases and make them more fatal. Okay, so this is kind of a preview of why you might think that our effects on overall mortality are going to be a bit larger than our effects on smoking related mortality. Okay, and finally, we're going to define some placebo causes of death. As I said before, We don't think homicide should be caused by smoking as an adult, and accidental deaths that are not fire related. So this is going to include auto accidents. This is still going to be an imperfect placebo if we do think that there are behavioral effects. If you're more likely to drink alcohol, for example, if you're a smoker, that could affect car accidents or vice versa. Okay, so for the outcome for mortality, we want to calculate mortality rates. Okay, so we're going to collapse the data and take sums for a given birth state. Remember, we're using that to proxy for teen state, a given birth year and death year. Okay, so our policy variation, is going to occur at the level of birth state and birth year. Okay, that's how we're going to map you to your teen taxes. Okay, I'll say a little bit more about that in a second. So to create the rates, then we have some of, oh, did someone want to ask a question? Okay, we have a sum of deaths per cell overall and by sex. To normalize the numerator into a rate, we're going to use the 1990 census, 5% sample. And what's nice about the 1990 census is that they have birth state. So we can collapse the census to the number of people who are born in a given state and birth year. And that's going to be the static population that we use to divide the numerator and get the rates that we want. So we're going to, basically the denominator is going to consist of anyone who was alive in 1990. And then we're going to match those people to the mortality rates by their age or by their death year minus their birth year. So we're going to age the sums forward to cover the years of deaths that we have, which is 1990 to 2018. Okay, so an example would be of our outcome would be share of individuals born in New York in 1950, right? That's their birth cohort who died in the year 2000. Yeah, and then so the way we get that again, it's by aging the 1990 census forward to 2000, assuming that population in 1990 is static. Okay. So some summary statistics for those two data sources, the tobacco use survey and the death certificates. We have the average age across both samples is going to be about 40. As I said, it ranges from 20 to 75. The birth cohorts we have are approximately the same. So we have 1943 to 1998 in the CPS. And then because we use the 1990 census as a denominator right now, we just have the birth years being 1943 to 1990 for the death certificates. Right now, as I said, we're working on expanding the death certificates we use to earlier decades, but not for this presentation. Okay. In terms of taxes, so we're going to express all the taxes in $2005. The teen tax, as I've said, is measured as the average tax in your state of birth, which is either, or sorry, in your teen state, which is either proxied by your state of birth or your current state of residence when we're using smoking. And we're going to average that from age 14 to 17, but our results are robust using other age ranges. Okay. One thing that I want to emphasize is that, so what does this graph show? This graph shows average real state tax rates across the United States from 1950 to 1972. You can see that starting, so there's kind of different eras. So from forward. Okay, so from 1950 to 1972, remember that our earliest cohort was 1943. And so we're going to have people who are teens starting in 1957. From From 1950 to 1972, there were actually a lot of state increases in taxes. And so that variation is going to be very useful. Then there was this downturn where there was really a lot of inflation, not a lot of state tax increases, less inflation, not very many state tax increases from 1981 to 1998. And then kind of after 1998, this is the era that most people are familiar with, where after the master settlement, a lot of states started increasing their tax rates by a large amount. But what we're trying to emphasize here is, while most studies of the effects of taxes on smoking focus on this period, there's actually a lot of policy-driven state variation in these earlier decades. Okay. And we can see that if we look at, so what does this table show us? So if you kind of focus on the right side of the table, we're looking at state level differences for these different eras. So what would be, for example, the difference in the state real rate from 1950 to 1972. If we look then across states at the 10th percentile, the difference at the state level is going to be 9 cents. The 90th percentile, it's 52 cents. And comparing that across the different areas, you can see that there's actually quite a lot of variation at the state level, right? Not just when we average across states. Okay, and then finally, we have a number of control variables. So we have, our assumption is that the tax variation is not going to be correlated with other policies or economic outcomes occurring at the state level at the same time. And so we control for the unemployment rate in the years that you were a teen, and then other smoking variables such as public smoking bans, and the minimum purchase age within the state over the years in which you were 14 through 17. In addition, we might think, for a variety of reasons, that first, we might want to control for what's going on when you're an adult in terms of these variables for a variety of reasons. One is that they are important determinants of smoking. So we want to control for the adult tax rate. The other is that there's a lot of persistence in policy over time. So we want to separately control for the adult rate and the teen rate, just in case they're very correlated at the state level. Okay, so we're going to control for all of these policy and economic variables, either in the year of the survey for the smoking, the TUS, the tobacco use survey of the CPS, or in your year of death. Okay, and those are going to be controlled for in the adult state. Okay. All right, so these are our two identification strategies. The first one is when we are looking at adult smoking. Okay, so the outcome, as I said, is this extensive measure of smoking in the year that you're surveyed in the tobacco use survey of the current population survey. We have our teen tax measure, we have our adult tax measure. At the individual level, we're going to control for birth year by age fixed effects. This is going to help us control for, so remember the tax policy is going to vary at the cohort because it's matched to your age when you're 14 to 17 and teen state. And so what would be necessary to control for, if this is kind of a difference in difference type regression, would just be your birth cohort and your teen state, but we're actually going to control for birth cohort times age, right? So the age is going to be your survey year, because the different cohorts are going to have very different age profiles in smoking and death outcomes. Okay. And then when we're using the CPS, we're going to also control for some individual level covariates and robustness exercises, gender, race, education. We don't have those in the mortality data. This next term is going to be the adult dated policy controls. Here we have the teen dated policy controls. And then we have our state fixed effects, where the state is, again, the state you're living in as an adult, but we're using that to proxy for the teen state. And then finally, across both specifications, we're going to control for state-specific linear time trends in your birth cohort. And these are going to control for a number of unobserved phenomena that might be related to the passage of taxes. So there's some work showing that anti-smoking sentiment is at the state level, which can move gradually, is going to motivate the passage of tax increases, and it will also control for economic factors at the state level that are changing over time that could motivate states to want to increase their tax rates. Okay, so our key parameter here is alpha 1, which is the causal effect of teen tax on smoking behaviors when you're an adult, and we're going to cluster the standard errors by state. And then for the adult mortality rate regression, it's going to be very similar, all the same controls to the smoking regression. The key difference is that the data is collapsed to the level of birth cohort, birth state, and year. So we can't put in those individual level controls, race and education, but we are going to show you separate results by sex. And again, the other key difference is that we observe birth state instead of current state. Okay. So all of the other controls here are the same. I'm just trying to make sure we get to the results before the end. So here the key parameter is beta 1, which is the effect of a $1 increase in teen tax on the mortality rate. The other key difference with this regression, because it is collapsed to the cells, which are defined by birth cohort, birth state, and year of death, is that each cell is going to be weighted by the population within that cell that we get from the 1990 census. Okay, talked about the identification strategy. Suddenly got concerned yesterday that I didn't have enough slides, and so I added a ton of extra ones, seeing that it may have been a little bit overkill. Okay, so let's get to the results now. Thank goodness. So we're going to show you results first for the smoking outcomes, just like I presented the identification strategy, and then for the mortality outcomes. Okay, so what we find here, I have some notes for each slide, so I'm just going to cycle down to my notes. Just 1 second. Perfect. Okay. So what we find here is that this $1 increase in teen taxes is going to lead to a 1.8 percentage point decrease in adult smoking participation, which is 7.7% of this mean rate of 23%. We can see that the effect is, just comparing the coefficients, is larger for men than women in magnitude, although those two effects are not statistically different. Okay, so it's suggestive evidence that men are more responsive. Okay, and again, remember that these effects are these long run effects, right? They're not contemporaneous. This is saying that the higher taxes you faced in your teen years, the less likely you are to smoke at about age 40, if that's the average age in our sample. Okay, so that's our first finding. Okay, if we then turn to the mortality results, for the pooled sample, we see that there is a reduction in them. So this is going to be mortality rates per 100,000. Okay, I didn't say that when I was setting up the data, but the rates are per 100,000. So a $1 increase in your teenage cigarettes taxes is going to be associated with 24.09 fewer deaths per 100,000, which is a 6.4 increase in mean decrease of the mean all-cause mortality rate. Okay. In this case, we really can reject that the male and female effects are different. So for men, we have this effect, which is quite a lot larger. It's going to be an 8% decline, this 36.99, associated with the $1 increase. And for women, the effect is not precise at the 5% level, right? This is 10%. And it is 4% of the mean rate. Okay. If we then look, so that was all cause mortality, right? If we then look at our smoking related mortality effects, we can see that one thing that's interesting is that it's a bit more precise for women. Again, the magnitude of the effects are very different across men and women, and we can reject equality. The pooled effect, as well as both of the effects by gender, are going to be about 75% of the reduction in overall smoking mortality. And we talked a little bit about why this measure, while we think it's going to get most of the smoking related deaths, may miss some of them, but it's good to see that it is the majority, the vast majority of the overall effect. Okay. If we then look by type, okay, so this is interesting. So this is going to be the smoking related mortality, but it's going to break it down into different causes. So if you remember, I said smoking related mortality is a collection of causes of certain types of cancer, certain types of heart disease, all diabetes, certain types of respiratory disease. This pooled means across men and women. We broke out lung cancer, even though it's also included in this cancer category. The largest effect is going to come in this reduction of heart disease. And, you know, you might be surprised by that, or the fact that the lung cancer effect is only marginally significant. And because we know that lung cancer is so tied into smoking, there I would just remind people that the cohorts we have are not so old. So they're going to be about 20 to 75 when we, at their age of death. The average age of a lung cancer diagnosis is 70. And so we might not, that's one reason why we're now trying to get additional data on earlier taxes and expand our sample to try to capture even older ages. But that's an ongoing work, okay? And then the largest percent decline is in respiratory disease, which is going to be a 16% decline. Which says that probably we're capturing a lot of the disease, within the category of respiratory disease, we're capturing a lot of deaths that are actually due to smoking, as we would expect. Final results from the mortality data is looking at these placebo causes, the homicides and non-fire accidents. And here, what's really striking is, so remember, these outcomes are very unlikely to be directly affected by smoking, but they could be affected by other, confounds that might correlate with the passage of taxes, if that's related to substance use at the state level. And so this is a really great placebo test for that reason. But what we see is actually, not only are the effects imprecise, but they're quite small compared to the means. And we can rule out for the overall effects as large as 5% of the mean rate of deaths due to these placebo causes. So that is the placebo. We have number of robustness tables, which I'm at time, so I don't have time to go through, but we show that our results are robust for controlling for individual level demographic variables and the smoking outcome, that we can, if you think that your year of death is endogenous to taxation, the cigarette taxes when you're a teen, then you might not like the fact that we control for adult dated controls. So we take those out and our results are robust. We can change the teen years. And then we show that our null effects exist in the placebo causes for each individual cause. Okay. So to conclude, this paper I think is super important because we're establishing a couple of novel key facts about the long run effects of cigarette taxes. In addition to the related paper, which also shows this first one, we show that teen taxes directly reduce adult smoking. It's not just a delaying of a smoking habit, but that they change long-term habits. And that teen taxes reduce mortality risk when older, especially smoking-related mortality, and among men for whom the effect on smoking may be a bit more sensitive. Are these effects still, is this still important given that smoking is so heavily regulated? Here's two reasons why it is. There's still continue to be these large increases in state cigarette taxes in recent years. And so to estimate the effects of these taxes, we would want to think towards the future when the cohorts that were facing these taxes in teen years are going to be benefiting from the mortality reductions. And then also something not said here is there's a lot of vaping in the United States. Some of the regulation that is reducing vaping has been, unintended consequence has been to increase smoking of cigarettes. And so to estimate the welfare effects of those regulations, we would want to take into account the long run health impacts of that legislation that's pushing people towards smoking cigarettes. That's it. Thanks for
excellent. Thanks very much, Katherine.
all your attention.
Yeah. Appreciate it. Okay, now the floor is open for discussion, please. Q&As. Are there any questions? Any comments?
May I start as usual?
Of course, Bernardo. Well,
thanks, Katherine, for the presentation.
Of course.
My first question is, about the gender difference, and especially so you find that taxes in teen while you're a teen reduce the likelihood of both genders to smoke, and
yes.
the difference is the reduction is slightly larger for male than female, but you said that the difference is not statistically significant.
Yes.
But then when you move to mortality, I was impressed that the effect was much larger for male, I think 3 times than for female, if I remember correctly.
That's about right.
Do you have any ideas of why?
Yeah, that's a great question. So I'm hesitating a bit to make, it's tempting to make the direct comparison between the smoking results and the mortality results. And it's somewhat difficult to do so because we have different ways of measuring state. So if there's more migration out of state across gender, that might affect the relative measurement error in both estimates. But aside from cautioning on comparing the two results, where also another thing to say is the CPS results the smoking results are not strong enough to be used. They're too noisy to be used directly as an IV, so it's hard to think about what estimate to scale them, to scale the mortality results to. don't know that we have, that I have a kind of behavioral explanation or health explanation, though, like, so there isn't actually a lot of evidence that I know of, at least from the literature, on the responsiveness of men versus women at the teen ages to, or even at the adult ages, to cigarette taxes. And so I can think of one study that finds that adults are less responsive to prices. But so I'm just saying, we're not sure exactly like how that behavioral response happens. And if maybe for women, it is more of a delaying effect, or, you know, there's some evidence that people will smoke less when the taxes are higher. We wouldn't get that in our smoking results necessarily, since we're just looking at the extensive margin. Yeah, so I think it's really interesting, but I don't know that I have some kind of insight into something that might be driving the manifestation of the mortality results, because actually women are more, I think the mortality rate for respiratory diseases like chronic obstructive pulmonary disease for women is higher at younger ages. So we might expect that they would be more affected.
Okay, well, we'll probably leave it at this. There is a question from Alexei Zakharov. Alexei, can you please read it up, or just any idea about the channel of the cigarette tax effect?
Is the microphone working?
Yeah, well, we can hear you. Please go ahead.
Yeah, so is this like purely the effect of a price increase? Okay, cigarettes are more expensive and therefore I buy less cigarettes, or are there network effects?
Yeah, so that's a really great question. So I think there could be network effects. We would have to think that, like, if it's between people who are married, that they are both born in the same cohort, right? Because the variation that we're looking at it in the same birth state. So we might think that men, so let's say like men are marrying women within their same, are more likely to marry women within their same birth cohort and birth state than not. And that those women are also affected by these incentives, then we could have some sort of like partner effect where you both are less likely to smoke and you influence each other. That could definitely be something that's going on. We haven't looked at that directly. I think we could in the current population survey to see potentially like who you're married to, and if the results are stronger among people who are married to people in their birth state and birth cohort, that would be nice.
Okay, well, that was useful. Francisco,
yeah,
please. Francisco.
I'm still wrapping up my mind about in the results on consumption, cigarette consumption. You mentioned you have a year of birth by age fixed effects.
Yes.
So you end up comparing people who are born in the same year and have the same age, but aren't those two things the same?
Oh, good question. So no. So if you think about our both the mortality data and the survey data, we're going to have, I'm sorry if you can hear, there's some construction outside.
Well, yeah.
We're going to have pooled across different years. So for the CPS, we have a bunch of different waves, right? And so we observe people who are born in a given birth cohort. It's cross-sectional. So we observe different ages for a given birth cohort. And then similarly for the mortality effects, we're going to observe people at the age that they die. And so when we interact the age with the birth cohort, it's going to give us, it's going to control for kind of the constant across space mortality profile by age for different cohorts. So we might think earlier cohorts had less access to health care in various forms, and so they're going to have a different trajectory of mortality over their lifetime.
Okay, well, thanks. Please, any further questions? Any other comments? Katherine, if I may, just perhaps to follow on what Alexei asked, but from a slightly different dimension. It's about the mechanism, and basically your treatment involves a couple of components. The first one is you raise taxes. Tobacco becomes more expensive and teens buy less and smoke less.
Yes.
And as a result, they become less addicted. Okay. And the assumption is that teenage years are the time where people are most susceptible to become a smoker throughout the rest of their life. But the question is about how durable is this teenage time effect. In other words, if when I'm a teenager, taxes are high, so I refrain from smoking. But then I grow up and the people that surround me are all heavy smokers and I catch up. So, the impact of this teenage years push grows weaker over time. And the question is if you can capture this, perhaps you can control or interact with the percentage of smokers in a particular locality, you know what I mean? And your effect might be dependent on that.
Yeah, so I guess, so in the other paper.
Catching up, because, you know, I recall my own teenage years and, you know, people start smoking different times. You do it later in the life, you end up in an environment, in an office, a university, whatnot. Everyone smokes, and then of course you start smoking, or vice versa. You were a smoker and no one smokes, and you quit just because you don't want to look outdoors.
Yeah, I mean, we would think if this is the rational model that you would maybe defer your smoking when you have less resources and the prices are high compared to how much you have as a teenager. But then if you have kind of these permanent preferences, or if there's this permanent cohort effect. So in the companion paper, we find that it's gonna so for every 10 teenagers that are deterred from smoking when they're 14 through 17 or 11 through 19, it's pretty similar. It's about 5 adults that are observed to not be smoking later in life. Again, the average age is around 40. It's a really interesting idea.
Just to make clear, I'm not disputing, I'm not denying that you're able to capture. I'm just saying that there is another source of variation later in someone's life that affects the strength. I think sort of, you know, multiplier of sort.
Could be really, really nice to add in, because I don't think our fixed effects would take that out, right? It would be something that varied at the teen state times cohort. Would kind of get into how many people migrate away from those social circles. Yeah, that's a really nice suggestion.
It might be a moderating factor of sort later in the life. Okay, well, thanks. Let me see if there are any further questions or comments. It's a great paper. It's a very convincing attempt to use a smart source of exogenous variations to measure the effect that everyone suspects of, but that's a very clean, nice empirical piece of work. So I'm glad we were able to learn this in our final session. And then we deserve a Christmas break. I wish everyone happy holidays, Happy New Year, Merry Christmas, whatever. Happy Hanukkah, somewhat belatedly. Bernarda, we will circulate an announcement about when we resume. We know that already after the New Year.
Well, first of all, thank you, Katherine, for presenting. I think we all
Thank you so much for having me. I really appreciate the opportunity.
Yeah, we all enjoyed the presentation and the discussion. And well, Leonid, yes, we do have our first speaker of the next semester. So it will be Mikhail Mamonov. And he will be presenting his paper titled Declining Regulatory Forbearance in the Presence of Bank Misreporting, a Quasi-Natural Experiment. So that's going to be on the 20th of January. Same place, same time. So, well, happy holidays to everyone. And see you in a bit more than a month.
We'll see each other in 2022. Believe it or not.
Yeah.
Bye-bye. Thanks.
Well,
bye.
Bye-bye.
Thanks, Katherine.